You don't like them? All right, I'll put more on next time. Yeah, it makes you actually have to read the question, and then when you get it wrong, you're like very angry at yourself because you didn't read the question. Um, so what we'll do today is pediatrics, and then we'll take a break, and we'll do musculoskeletal. And the MSK part is longer, so we probably will, we'll probably get through the peds in maybe an hour, a little more than an hour or so, and then the MSK is going to be a little longer, and it's going to be a little more stuff that fractures and things like that, which you're obviously going to want to be able to be facile with as we go forward. So one thing about pediatrics, of course, and it says non-skeletal, but there will be some pediatric skeletal stuff here. Yes, we're going to talk very little bit about bioeffects of radiation in pediatric, the difference between pediatrics and adults. Pediatric anatomy, which you would think is very much like adult anatomy, but actually it's not just that everything is smaller. Pediatric radiology is very, it's a whole different set of diseases than most adult radiology. There's a whole slew of diseases that only occur in the pediatric population. It's not like I'm going to show you all of them today, but pediatric radiologists are on the weirder side of radiology, and so because radiologists are on the weirder side of humanity, you can really be talking about some really freaking weird pediatric radiologists out there, and they're very, as you would want them to be. They are extremely detail oriented, and everything has to be right. And they're also very compassionate and kind to young children, which is a good thing to be if you're a pediatric radiologist. And of course, we will go through a number of the more common abnormalities for pediatric radiology. So let's talk about a little bit about radiation in children. There are a number of malignancies that are definitely associated with radiation exposure. And radiation exposure, when we're talking about pediatrics, doesn't necessarily mean medical imaging exposure. Although, obviously, as I told you before, that's going to account for some of the total dose. But most of the studies that were done on pediatric links to radiation and cancer were, huge trials of Hiroshima and Nagasaki, other large exposures that have occurred, Chernobyl, et cetera. So we're talking about humongous doses of radiation, right? But there is an association with leukemias, breast cancer as an adult when you're irradiated as a child. Back in the day, even before my day, people used to radiate pediatric chests because they thought the thymus was that an enlarged thymus was an abnormality, and that enlarged thymus, it was theorized, had something to do with other disease states in pediatrics. So they would take these kids in the 30s and 40s, and they would radiate the hell out of their chests to try to make the thymus get smaller, and that only gave the girl babies breast cancer when they got older. So we don't do that anymore. The thymus is a pretty innocuous gland unless you have myasthenia gravis, and it tastes pretty good if because fried thymus is some kind of delicacy in many, but not children's thymuses.
Please.
So there's we'll stay very clinical here, will we? So there's thyroid cancer. Again, all that radiation in the chest, in the neck. There's an incidence of thyroid cancer, and sadly, there is an incidence of increased radiation exposure and brain malignancies in children. Remember also, so I said it's not only medical imaging, so it could be something like a Chernobyl or a nuclear explosion, but it can also be medical radiation therapy. We are very conscious of radiation therapy in young children, and you want them obviously to survive their malignancy if they're getting radiation therapy, but then 10 and 20 and 30 years down the road, they develop a secondary malignancy that is related to radiation therapy. And so, so these are the kinds of things that when you're eliciting a history from a child or a mother or a father, has the child ever been irradiated for whatever reason? It's, and again, medical imaging generally is not the culprit here. It's usually something that's a much higher dose. Even mental retardation has been associated with prenatal exposure. And remember, of course, that we don't want to expose in utero when? In the first trimester, right? Because between 8 and 12 weeks especially, there has been an association of high doses of radiation and mental retardation. Curiously, it's also associated with smaller head circumference. So again, related to dose and gestational age at exposure, and 8 to 15 weeks is the greatest risk. This is always a tricky subject because when you are seeing a patient and there's a hovering parent and the child is ill, of course the parent wants to know immediately what's wrong, and they want you to tell them what's wrong, and they want you to do some imaging to tell them what's wrong. So, a baby that has a febrile seizure, a first febrile seizure, the instinct, of course, is to get a CAT scan. There might be a brain tumor. There might be something causing the seizure. But in febrile seizures, they're always negative. They're always negative. So, you really don't need to be scanning those children. You really don't need to be getting a chest X-ray on uncomplicated asthma. And asthma is something you're going to see walk in the office, walk in the ER all the time. You really don't need to be doing anything in the gut for a child with gastroenteritis. And I think for the most part, most pediatricians are very sensitive to that. ER docs, I don't know so much, but at least pediatricians know to say, we really don't need to be doing this. And, it's one thing for a parent to be frightened that their child is ill. It's another thing to frighten the parent and say, we really shouldn't radiate them because we could make the child ill. So it's a give and take kind of thing. So, as I say, most kids with headaches and wheezing don't need a head CT, don't need a chest X-ray. It has been suggested that you could reduce the entire radiation dose of the population if there were more strict referral criteria. And there probably would be more strict referral criteria if it weren't for attorneys and very, very concerned moms and dads who insist on knowing something right away. And it's very difficult to deal with that pressure, right? And always, of course, if you can, consider other modalities that don't use ionizing radiation, like ultrasound, if possible, if it's indicated. So that's all about pediatric radiation and things like that. A lot of the stuff that we talked about in the last couple of lectures definitely applies to that. So keep that in mind.
Dr. Moncalvo,
Yes.
when you say referral criteria, what do you mean? Like referral to a specialist?
No, what I mean is like, for example, there's in Canada they use a lot of referral criteria. For one of the things would be there's like for ankle injuries, right? If the patient has pain here or is unstable here, do nothing, do an X-ray, do an MRI. Okay, so basically you would checklist that, right, and say, okay, well, it's an uncomplicated asthma or it's the first time febrile seizure. You would say, okay, do nothing, and it would be great if that were all admissible, and it is admissible, but it doesn't matter. It doesn't you in our system, physicians are not absolved. They're not held. They're not indemnified against being sued or anything if they follow a criteria, even if the criteria is well established and is considered a standard of care. You can still get sued and you can still lose your shirt if you didn't do it for whatever reason. You got to go to attorney on the other side. So it is it's a nasty business. So as I said, children are not just small adults. There's stuff on pediatric imaging that you will see larger in children and not at all in adults. There are things that you will see that you would never see in an adult and will always see in a child. And the thymus is a perfect example of that. Um, we recognize the heart and the lungs, and then we recognize this big soft tissue density mass in the anterior mediastinum. It is anterior, and I'll show you in a lateral, I think I will. But just like any other chest film, you want to establish, is it a good inspiration film? You want to look for that thymus because you really should expect to see it on just about every newborn. Slowly over time, the thymus will get smaller, usually by 3, 4 years old. You're not going to see much of it anymore on an x-ray, but you will see it on a CT scan. In fact, you'll see thymus even into young adulthood on CT scans of the chest. And you just need to know that it's normal and there's nothing to do about it. There are abnormalities of the thymus. I mean, there are tumors of the thymus. There are masses of the thymus. And so if you've got an anterior mediastinal mass in a 12-year-old, the thymus should not be there to that extent. So you're going to see this normal thymus in kiddies up to 2 to 3 years old when it looks like this, when it's very prominent. Some of the more common ways that we image kids is when they're small enough, we'll do an entire, what we call a babygram. And that's a babygram right there. Because you can fit the entire kid on one cassette. And in the old days, it was a 14 by 17 inch cassette, so you could fit the entire kid on one. So why stop at the chest when you can have everything with one shot? It's really not an easy thing to do to collimate the beam on a little one like this, so just shoot the whole thing. And these are almost always newborns, neonates. So we see the heart will always kind of look plumpish. You want to, generally speaking, you always want to be looking at the heart and its configuration. Before we had cross-sectional imaging of any real stature, the smartest radiologists in the world were the guys who could diagnose congenital heart disease just by the shape of the heart, just by the bumps and lumps and bumps of the shape of the contour of the heart. Now, we don't look at it at all. We look at it, but we're not really looking at the heart, because if we want to evaluate the cardiac anatomy, we do MRI or we do CT or we do something, echo. We have so many other good ways to look at cardiac anatomy that just looking at the heart shadow and outline is not going to be the most accurate way to diagnose the tetralogy of Fallot or a transposition of the great vessels or something like that. I want you to draw your attention to a couple of the lines that are in this kid. Okay, there are two common catheters in the pediatric population, that in the newborns, especially the preemies. They're almost always going to have an umbilical artery catheter, and they're almost always going to have an umbilical vein catheter. The umbilical artery catheter should generally always take the same course. What happens is the umbilical artery is actually a branch of the iliac vessels. Okay, so the catheter, so when you're retrograding it, the catheter goes into the umbilical artery, down into one of the iliac vessels, like here, and then up into the aorta. And of course, the aorta is always generally to the left of midline, and certainly in almost all cases to the left of the IVC. So this catheter is going to be the umbilical artery catheter. The umbilical vein catheter, the umbilical vein, if you'll remember, connects with the portal vein, okay, and then connects into the IVC. So you've got the umbilical vein catheter generally takes a straighter course and goes up directly up the right side. So umbilical artery and umbilical vein catheter. And usually you'll want the umbilical artery catheter to be right here in the lower thoracic aorta, and the umbilical vein catheter just in the IVC, the intrahepatic portion of the IVC. So that is a pigostat. This is how you immobilize a kid. Kid's kind of chubby, isn't he? It's pretty cute. I had to find the cutest pigostat picture I possibly could find. But this is how we immobilize a kid to.
No way.
It really looks like something out of Ripley's Believe It or Not. But this is how you immobilize the kids to keep them from you know, I mean, they're not going to stay, they're not going to follow commands, and they're not going to sit still. And the technologist really has to try to time, like, because usually if they're in here, they're screaming, they're crying. So you try to just when they take that breath before the next scream, you expose it. So you try to get them at full inspiration. It's a tricky business being a pediatric X-ray tech. It really is not easy.
So cute.
That is a cute kid. And so you're going to get, you know, you're going to get generally an AP view. Okay, the beam is generally going to be in front, going anterior to posterior. Unlike in the adult, where we do PAs whenever we can, but in the kids we do APs, which will of course make the heart look a little chunky, right? Remember that. So an AP view for the pediatric chest. All the other principles that I, you know, went through in excruciating detail still apply. You know, silhouette sign, consolidation, interstitial markings, all that stuff. And the lateral, again, the same thing. You're going to see the, you know, the sharp angles of the costophrenic sulci. You know, the thoracic vertebral bodies are going to be in a little different shape than the adult. They're not going to be completely cornered off, which doesn't happen until, you know, later in your mid-teens, because the skeletal system, of course, is still quite immature, and it's the immaturity of the skeletal system that will, you know, obviously tip you off, among other things, that this is a pediatric patient. Another normal chest X-ray. You've got to give a little more leeway when you're looking at a pediatric chest with respect to the lung markings, and you know, be a little less quick to call, you know, interstitial abnormalities, because when the kids are this small, there's a lot of vessel. The ratio of vessel to air is greater in the pediatric population than in the fully formed adult chest. So there's a lot more air in the adult lung compared to the amount of vascular markings. But in the kid who has quite small, you know, small intrathoracic volume and small lungs, the vessels tend to take up more space, and so they always look a little more prominent than you would expect them to look like in the adult population. Notice that there is still that anterior clear space in the pediatric population. Now, in this kid, the thymus is not quite as prominent, and in the anterior part of the chest, there is a clear space. Here, also, clear space. Not every thymus is huge, okay? It's obviously going to be quite variable. But when you do see a large thymus in a young kid, don't be quick to call it a mass. Any questions on pediatric chest or anatomy? Looking good? So there are a number of rather unique chest abnormalities in the newborns that is something that you're definitely going to encounter if you're going to be rotating through a neonatal ICU, or, you know, even a healthy newborn. There are going to be things that you probably need to be familiar with because they're very common. And two of the more common ones that you need to know about are the transient tachypnea of the newborn, also known as respiratory distress syndrome or hyaline membrane disease. Transient tachypnea of the newborn as opposed to RDS or hyaline membrane disease. Transient tachypnea of the newborn is generally an entity that you see in full-term infants and generally clears quite quickly. RDS or hyaline membrane disease is definitely an entity that occurs in premature babies, and the more premature, the worse it is. And it generally is that one of those things that is really what's keeping the baby really, really sick. We'll talk about why in a couple of minutes. There's meconium aspiration syndrome. There's bronchopulmonary dysplasia. I'll show you some entities, some images of those. But the two that I really want you to think about are the transient tachypnea of the newborn and the RDS. So what is there's hyaline membrane disease. I just put these slides together yesterday, so I apologize to you. I should have been transient tachypnea should have been first, but here anyway. Hyaline membrane disease is the entity that is seen in the premature, okay, the premature infant, generally less than 34 weeks. So what happens? What's happening between 34 weeks and 40 weeks that would prevent a full-term newborn from having the same problem? And the issue is this thing called surfactant. Surfactant is a protein that the near-term fetus begins to secrete into his lungs and into the amniotic fluid. That when the lung hits air and those little alveoli, balloons, remember those things? When they open up, the surfactant is what keeps them open. Otherwise, they're just going to collapse on themselves again. And so the preemie doesn't have a sufficient surfactant, takes a breath, the balloons open up, and then they just close up again. So there's no gas exchange. So that's bad. Again, always seen in prematurity. You're going to see low lung volumes, so the lung is not going to be well expanded at all. There's going to be these patchy granular densities in the lungs with there might be some atelectasis, there might be some air bronchograms, which you can kind of see snaking in there, maybe up here. And generally is going to present itself pretty quickly after birth, within 4 to 6 hours, the kids are going to be in respiratory distress. Generally speaking, the neonatologists are expecting it. I mean, they're definitely going to be doing everything they can. They'll probably intubate the patient, and I think they actually have there's actually surfactant that we've been able to manufacture that they'll like squirt down in that lung to try to keep those alveoli open. That's transient tachypnea of the newborn. I'm looking at this thing going, what is going on? There's something wrong with this kid's chest. But this is the transient tachypnea of the newborn. Okay, so the thing about it is it's got this kind of ground glass density to it, and normal chest X-ray. What the hell am I doing? I'm sorry, folks. I beg your pardon. Just shut up. Here we go. I'm sorry. I must have forgot to put that transient tachypnea slide in. I'm sorry. In the hyaline membrane disease, low lung volumes, patchy densities, and scattered air bronchograms. Now, the meconium aspiration is something that kind of a little gross, but something that we got to talk about. Generally, you see this in the post-term infants. Okay, who've been in there maybe just a little too long, and generally in the act of birth, had a wee little accident and let some of that meconium fly into the amniotic fluid before they got out. Meconium, if you'll remember, is that stuff that builds up in the infant in the fetal gut during gestation. Generally, it passes once the baby is born, but if they let loose with that stuff in utero, and of course are breathing essentially amniotic fluid, meconium causes a chemical pneumonitis, and can be thick enough so that it actually causes small airway trapping or small airway obstruction and air trapping. So you get these what are called diffuse ropey densities. Doesn't really project particularly well here, maybe better on your slides, where you might get some areas of a little overinflation, so patchy emphysema and atelectasis. So in meconium aspiration syndrome, unlike in hyaline membrane disease, where there's low lung volume, in the meconium aspiration syndrome, generally you're going to have normal to increased lung volumes and kind of in a patchy distribution. So you got aeration here, but not such good aeration over here. And because whenever you have the possibility of some airway obstruction in little children, you always have the possibility of getting pneumothorax or pneumomediastinum. That would be, of course, air between the pleural linings, because what happens is the air may ball valve into a subsegment but can't get out, and then boom, something blows, a little alveolus blows, and the air then gets out into the interstitium and into the pleural space. Or that air can work its way into the mediastinum, and you get pneumomediastinum. Neither of those are shown on this image. And then the last thing I want you to be familiar with is this entity called bronchopulmonary dysplasia, which really is a sequela of long-standing oxygen therapy. If you're born premature and you have RDS and you get intubated and you're on the ventilator for several weeks, generally getting 100% oxygen or near about. This generally it's obviously the oxygen is necessary to keep the child alive, but it's also quite damaging to the lung tissue over time. And you'll get this, if you need oxygen at day 28 of life to maintain your oxygen tension of greater than 50 millimeters of mercury, and you have an abnormal chest X-ray, that is the definition of bronchopulmonary dysplasia. So the lungs are generally over-aerated. They have these coarse, irregular linear densities and fibrosis, and have like a sponge-like appearance. Now you will say to me, that doesn't look any damn different than that. And I would say you're probably right, except this child is 4 days old, and this child is 30 days old. And it's really important that you know a little more about the natural history of how the child's been treated, so that you can get a good idea of what's going on. So, on this chest X-ray, the lungs are overinflated. There's an endotracheal tube, there's a nasogastric tube, there's an umbilical artery catheter, there's an umbilical vein catheter, so you've got these kind of ropey linear densities and pulmonary overinflation, and the kid's O2 sat is not great. Okay, so let's move away from the newborn state and start talking about the childhood lung diseases. And these can be very broadly broken down into the reactive airway diseases and bronchiolitis, the acute, the kid with an acute cough. And then again, there's asthma, which is very common. But asthma is a clinical diagnosis. It's not a radiographic diagnosis. So your radiology report should read radiographic features consistent with a diagnosis of asthma, not asthma, because that is, again, not a radiologic diagnosis. And then, of course, pneumonias, which are generally very similar in appearance in the pediatric population as they are in the adult population. So this idea of reactive airway disease, and that could generally be viral, but it can also be bacterial. We talk about this thing called peribronchial thickening. So here's a normal chest, and I want you to draw your attention to the hilar regions here. Of course, there's blood vessels in here. We expect to see some density. But here, it's a little chunkier and doesn't really quite project particularly well. But if you can see some scattered areas of small central lucencies with thickened airways, the thickened walls around them, it doesn't really project particularly well. There's some up here, there's some up here. That's the bronchial tubes, basically, the lining of the bronchial tubes are inflamed. Again, that tends to be viral in nature. These kids are coughing, they're wheezing, and they have other prodromes of upper respiratory infection. And very common, you're going to see this all the time. And you're going to see a lot of radiology reports that say peribronchial thickening and prominent interstitial markings or something like that. But it's important to note that there's no airspace consolidation. There's no silhouette sign. There's no dense right middle lobe. And this is generally a tip-off that this is what's going on here is generally a viral bronchiolitis, reactive airway disease. Unlike pneumonia, which is not dissimilar to any other pneumonia I've been showing you during this course. Again, in the pediatric population, you can get a viral pneumonia. It doesn't necessarily have to be bacterial pneumonia, but the hallmark is, again, going to be this interstitial or airspace opacities. And the bacterial pneumonias tend to have more of the airspace opacity finding. They tend to be more like a an airspace consolidation that you would see in the chest X-rays. Um, the viral pneumonias can be tricky. I mean, they could have a very near normal chest X-ray. So just because you get a chest X-ray report back that says normal or minimal increased interstitial markings, doesn't mean the kid doesn't have a pneumonia. And especially up to the age of 2 years, it's going to be sometimes very difficult. But the bacterial pneumonias will generally have more airspace consolidation. The ingested foreign body is not uncommon in kids for some reason. They like nickels and quarters, and you can find just about anything in there. Generally, the stuff is going to stick in pretty typical places, right at the thoracic inlet, right where the aortic arch and the esophagus come together, and then just above the diaphragm at the esophageal hiatus there. The thing to remember about foreign bodies is they're not always obvious, and sometimes can be very difficult to see. Sometimes you won't see them on an X-ray, and you need to do a CAT scan. But always be suspicious, especially when kids are coming in and they're drooling and they're not. Mom says I can't find my hat pin or something. So this is a very typical location for the swallowed or ingested foreign body. Remember that it's always good to get 2 views. You don't know where that thing is necessarily when you look at the frontal view, but on the lateral, it's right behind the airway. That's where the esophagus lives. So pretty easy to figure that one out. Generally, someone's going to have to go in there with a little scope and pull it out. It's not going to pass on its own. Certainly nothing that large. So in contradistinction to the ingested foreign body, there's the inhaled foreign body. And the inhaled foreign body is actually a little more worrisome because of what it's going to do to the lung behind the obstruction, right? Obviously, if it completely obstructs the bronchus and no air can get through either way, then over time, the air that's in the lung behind the obstruction is going to resorb the air, and the lung is going to become atelectatic. And there's going to be volume loss on that side. So if you've got a large chunk of lung that has no air in it, the diaphragm is going to elevate, the heart may shift over to the same side, all of the principles that we've discussed in the past. But the thing you want to be aware of is this partial obstruction, this ball valve obstruction, where air can get past on inspiration but can't get out on expiration. So you keep expanding and expanding and expanding this segment of lung. A peanut. Sometimes it's good to get an inspiration and expiration view so that on the inspiration view, the lung looks pretty normal. But on the expiration view, the normal lung has collapsed normally, but the part of the lung that is obstructed hasn't collapsed. So now you've got a mismatch. So getting an inspiration and an expiration funnel view is usually very good. Sometimes doing cubitus views are useful. But if you don't catch that offending agent, something's going to get infected behind that obstruction, and you're going to get a pneumonia. So on this particular case, here's the inspiration and expiration chest film. So on the inspiration view, looks pretty normal. Well, you could maybe argue that the right lung is a little more hyperlucent than the left, but right away you look at that and go, yeah, that's pretty normal. But then when the kid blows all his air out and you take a picture, the left lung has collapsed appropriately, but the right lung hasn't moved, right? Because there's something blocking that right mainstem bronchus, preventing the air from getting out. On expiration, the mediastinum pushes over to the left because there's still a lot of air here in the right lung. So pneumothoraces in kids, especially kids on ventilators, is really an important thing to look for. If you're in any age group, if you are on a ventilator, you are almost by definition undergoing positive pressure ventilation. That means that the air is being forced into your lungs with positive pressure. And if there's an air leak between your lung and your pleural space, and you are forcing air in under positive pressure, you are forcing air under positive pressure into your pleural space. So you are setting yourself up for a disaster by always making that pneumothorax bigger if there's an air leak. So the pneumothoraces in kids are not always this obvious, but obviously this one's been going on. Here's the endotracheal tube. There's a nasogastric tube. There's your umbilical artery catheter. But this one's been going on for a while because this right hemithorax is just filled with air, and there's the lung, which really has maybe very little air in it. But all this air is just going into this pleural space. So pneumothoraces in kids are notoriously difficult to see. This one's obvious, but the problem is the kids are usually supine. They're in an incubator. It's very difficult to sit them up or lie them on their side or do something like that. So you really have to be very cautious, and you have to, definitely let your radiologist know if you're really concerned that the kid has a pneumothorax. Any radiologist should be looking for a pneumothorax in any pediatric chest X-ray where the kid is intubated. That's one of the things that we check off in our list in our mind. Is there a pneumothorax? I may or may not mention it. I should mention it. I mention it in my reports. Most radiologists will. And if you're concerned and he doesn't say it, call him up and say, "Can you look and just tell me for sure that there's no pneumo?" A lot of times these pneumos are going to sit at the base, and you will only see a little thin wisp of lucency at the base. You won't see them typically the way you see them in adults, where you see them up here with the pleural line sign. There will be a pleural line sign, but it may be very, very difficult to see. It may be medial, it may be posterior, it may be inferior. A lateral supine film can often show the pneumothorax somewhat better. So here's a frontal view, and here is a kind of subtle pneumothorax. It's down here. Notice how it looks quite different than the normal left side. There's lucency here, and here's the diaphragm, and then there's some lucency out here. But if you lay the child down on their left side down, right side up, now you can see, the air collecting independent. The air is supposed to go up independent in the hemithorax, and there it is. Here's a tension pneumothorax in a pediatric population where, of course, everything's being shifted over to the right. So all the same principles apply that we've talked about with pneumothorax. But know that in children, in the pediatric population, they can be very, very difficult to see, and you really have to be on guard for them. Okay, let's move a little bit out of the chest and to the neck, where there's a couple of really interesting and important things that I want you to be able to look at when you look at the pediatric neck. So here's the normal anatomy. Okay, so the normal airway, the larynx is going to be right about here. The epiglottis is going to be right about here, and here's the hypopharynx and oropharynx. This is the prevertebral soft tissues, and generally speaking, the prevertebral soft tissues should be at its most thick, almost about the width of a pediatric vertebral body. So about that width there, about that width there. That's good. That's normal, and there should be nothing back there except soft tissue density. And on the frontal view, you want to see, if you can, the air column in the trachea, and you want to see it kind of have these soft shoulders to the cords, and generally that's really what you're looking for on the frontal view. Pediatric necks are difficult because, again, kids they're not cooperating, they're crying, and depending on what phase of inspiration or expiration that the neck is shot at, your airway is going to look odd. Okay, if the kid's just quiet and breathing quietly, it's going to look like this. If the kid's valsalving and screaming, it's sometimes it would be nice to know exactly what phase of respiration the kid was in, but even the tech doesn't know, because the tech just wants to get the kid done and get it out of there because it's screaming. And this is some, a pediatric radiologist really needs to be very patient. When I did my, as a resident, we do like 6 or 8 weeks of peds, and I did mine at Children's Hospital in Philadelphia. And you know, the kids are just sick. They're just terribly sick kids, and it's so depressing. And I found it very difficult. I had I was just married and I had young kids of my own. You're like, God, every day, you're like, this is going to happen to my kid. My kid's going to have these horrible diseases. It really takes a very strong person to do it. It's very difficult. Anyway, so a couple of things in the neck that are common. Luckily, this isn't as common as it used to be because of vaccine and other things that we've been doing. But common and potentially deadly. Epiglottitis is definitely the one or two things that I want you to be able to recognize when your kid comes into the ER with stridor, right? Cannot get a full breath of air, is wheezing, stridor, fever, neck pain. Generally, it's Haemophilus influenza, but can also be pneumococcus or streptococcus. These kids are drooling. It's painful to swallow. They're in respiratory distress, and they're between 3 and 6 years old for the most part. So epiglottitis tends to be that age range. These kids get an upright lateral soft tissue neck film. You don't want to lay these kids down because that's when they're going to close off their airway and go into respiratory arrest. And nobody wants that. So you really definitely want the kid to be upright, true lateral, and you want to look for that thickened epiglottis. I don't know if you can see it here on the, but the epiglottis is right here, and it looks like just a little sail, just a little, thin wisp of tissue. Remember, the epiglottis, the function of the epiglottis is to close the airway when you swallow, so that what you're swallowing doesn't go into your airway. But if you see an epiglottis that looks like this, almost, so this is, I think this one is normal, and then there's this thing here, sorry, which almost looks like a thumb on an X-ray. Not my thumb, but I mean, it looks big, and it looks way too big to be, when you compare it to the normal size. Also notice in this particular instance how the hypopharynx is really distended with air, because this child is really an extremist. So this is epiglottitis, and it's definitely something you're going to want to be aware of. Another very common thing is croup, which tends to have that barking kind of cough that we've all heard. I mean, I don't know, my kids used to cough like that. They used to bark all the time, and I thought that they had croup. Well, it must be a particular sound that I have forgotten. But I remember taking them in once, and I was like, that's not a croup cough. That's just a regular cough. I'm like, okay, if you say so. When it's your kid, it sounds like croup. So this is also known as laryngotracheal bronchitis in a younger age group than epiglottitis. Okay, so 6 months to 3 years. This is usually viral, and it usually follows a cold or an upper respiratory infection. And then they get this brassy cough like a barking seal. What happens is that I told you that there was that soft shoulder of the tracheal air shadow in the neck on the frontal view. Well, this becomes more steeple-like. Okay, so you get this steeple sign on the frontal view. These X-ray signs are not specific because, again, depending on the phase of the patient's respiration, you might get a pseudo-steeple-y sign on the X-ray. So here is the normal, soft shoulders. Okay, this is the trachea below the level of the cords, and then here's going to be the cords right here. And then here's that steeple sign where you lose the soft, rounded shoulder, and now you've got this. So, this is pretty typical for croup. Okay, this is one of my favorites because you can really help somebody out when you make this diagnosis of a retropharyngeal abscess. Notice on the normals, Here's a normal. Notice again that retropharyngeal soft tissue or the prevertebral soft tissues, just about the width almost of one vertebral body. You know, that's okay, and there's no air in there. It's just perfectly pristine. But then you get this film where this is the prevertebral soft tissue, and the airway is here. It's being pushed, and this kid's febrile and sick as hell. And so this is a retropharyngeal abscess, and the thing about retropharyngeal abscesses that are life-threatening, among others, including the fact that they can impinge on the airway and cause airway obstruction, is that the retropharyngeal space actually communicates with the mediastinum. So this infectious process works its way down. Here's a CAT scan through the mid-neck, going a little lower, lower. Now we're almost at the thoracic inlet. Here's the top of the lungs. Notice that this fluid collection, which is the big abscess, is going into the chest. It's in the mediastinum. So this is nasty and very difficult to drain completely. These kids, I mean, at this point, this thing probably has to go to the OR and be opened and drained. Generally, if they're small, they're treated with antibiotics and they get better. But you don't want to ever let it get to this thing. And this is a tremendously huge abscess. Now, these abscesses can get air in them. So you're always looking in that prevertebral space for little globs of air. If you think it's wide, if it's inflamed, but retropharyngeal abscess is a medical emergency. Most kids today, if the doc even thinks he has retropharyngeal abscess, he's going to CAT scan. So you may never see a better example on an X-ray or a CT scan because that's a huge abscess. Okay, so let's now move out of the neck. We're done with the chest. We'll go below the diaphragm, and we'll talk about the pediatric bowel. Any questions? Are we good? Good. Pediatric bowel obstructions, for the most part, look like adult bowel obstructions. We haven't really talked about the GI tract yet. The last lecture, which was on August 6th, will be GI and GU. So I haven't really introduced the principles of radiographic appearance of bowel obstruction just yet. But for the most part, you can figure it out. In a neonate, you expect air in the stomach within 2 hours of birth, air in the small bowel about 6 hours, and air in the rectum 24 hours after birth. But there are a number of different causes of newborn and pediatric bowel obstruction. Everything from congenital anomalies of the way the bowel is put together. You can have atretic segments of bowel or absent segments of bowel so that stuff goes in and ain't coming out anywhere because there was an ischemic event or a congenital anomaly of bowel in utero. There can be mechanical obstruction. There can be paralytic obstruction of bowel, Hirschsprung's disease. You may have heard of that one. So what we really are trying to do is identify what generally is the level of obstruction. And it's not as easy in the pediatric population as in the adult population. Adult, small bowel, and large bowel can generally readily be distinguished by the radiographic appearance. Pediatrics, not so much. So you got to be a little cautious about that. So let's just kind of work our way through the bowel and talk about some common areas of obstruction. If you happen to be a male baby and you are projectile vomiting like you are in The Exorcist, you might have hypertrophic pyloric stenosis, which is an entity which is basically the overgrowth of the pyloric muscle, the muscle between the distal stomach and the proximal duodenum. And that muscle just spasms and it will not open, and so the baby cannot empty his stomach. And it's not particularly uncommon. It's probably tested for much more commonly than it actually exists. So if you were to bring your child to an ER or to a pediatrician and the child was male, even though that doesn't matter anymore because they scan just about anybody, and say, baby's been throwing up all over the place and it's shooting across the room and it's crazy. the first question that someone should ask you, well, is it green or is it clear? Because it actually makes a difference. Because if it's non-bilious, which means that it's clear, that means that it's not getting to the duodenum where the bile joins the stream, right? So that would actually be more concerning for a high-grade gastric outlet obstruction of some reason than bilious, green, yucky, vomitus. And then the doc presses on the belly, and he may or may not think he can feel the hypertrophic pyloric muscle itself, which will feel like an olive, And if you've ever felt one, I remember feeling a couple in training. It's quite an impressive feel. But generally, we used to do these upper GIs, and then so you'd have the babies, you'd give the babies some kind of positive oral contrast, gastrografin or a little bit of barium or something. And then under fluoroscopy, you would see what happens. And you might get lucky enough to see an image like this, where here's the stomach. This is a little reversed. So here's the stomach, with the white stuff is the contrast. And then you get this kind of big shouldering here, and a tiny little bit of contrast squeaking through the pylorus, and then distally in the jejunum. So, the stomach is already distended with stuff. This really, if this is normal, it really should be opened up quite a bit wider than that. But we don't do these anymore. We don't do positive contrast for upper GIs. Don't know. It's definitely male. Firstborn, I'm not so sure about that. But when I was taught, it was male. It definitely has a preponderance for male babies. I have seen them in females though. So we don't do the positive contrast studies much anymore. We go right to ultrasound. And ultrasound is very good for a number of reasons. No ionizing radiation. In a little baby, the stomach and pylorus is right there. It's right under the anterior abdominal wall. So you don't have to throw the ultrasound very far to get high quality, high resolution images. And so we use a longitudinal probe, usually 5 to 10 megahertz, which means the higher the frequency, the higher the resolution, but the shorter you can actually throw the beam, right? Once you get down here, it gets to be nothing. So here's a cartoon of the stomach and the very dilated, thickened pyloric muscle. And if you can hypothesize with me, here's the pyloric canal. Here's the pyloric canal. Okay. Here's the muscle, the anterior, and here's the posterior part of the muscle. Generally speaking, we will measure. We'll measure the length of the canal. We'll measure the thickness of the muscle. We'll measure the thickness of the entire pylorus. There are a number of indexes that have been published. If it's this plus this minus 32, it's pyloric stenosis. I think generally it's largely a combination of imaging and clinical diagnosis. If the kid has it clinically and the pylorus looks thick and fat, even if you can't palpate the olive or whatever, the kid probably has it. They may watch for a little while, but if it does not improve, then they're going to go in, they're going to surgically do a little, just going to put a little nick in that muscle and just let it open up a little bit. And then those kids do fine. So hypertrophic pyloric stenosis is a favorite. Working your way now through the small bowel and into the colon is another, thankfully, not common reason for bowel obstruction in a kid, and that is intussusception. So what does intussusception mean? Basically, it means kind of like being able to, if you've got a long tube and you start feeding the middle part of the tube into itself so that you actually telescope the tube into itself. This is what happens. In intussusception. In pediatric population, it's usually a benign process. In other words, there's nothing necessarily causing the bowel to telescope in on itself. In adults that have intussusception usually have a tumor or some mass in the bowel that is basically being pulled by peristalsis until it finally starts pulling the bowel wall with it. And then, so there's usually a leading focus in adults, but in kids, there isn't any underlying pathology that causes it, but when it does happen, it usually happens in the ileocolic region. So the distal small bowel will intussuscept into the cecum and proximal small bowel, and then the small bowel becomes obstructed because nothing can get into the colon. So you'll get dilated small bowel, and you'll have this lump or this mass up here in the ascending colon. This is the image of a barium enema in a child. So we've got a tube here, contrast going in the rectum, sigmoid colon, descending colon, splenic flexure, transverse colon, and then bang, it's blocked. Okay, so this is a pretty classic location. And why would we want to even bother doing a barium enema on a kid that has an intussusception? Well, you can actually reduce the intussusception by the hydrostatic pressure of the barium. So in the best of all worlds, you hook this barium up. It's usually either barium or gastrografin. You put it up on a pole, kid's on your table, and you run it in. You diagnose the intussusception where the kid is obstructed, and then you run the pole up a little higher, a little higher, a little higher, and you increase the hydrostatic pressure of the fluid that's in the colon. And if you're lucky, you'll start seeing that intussusception slowly reduce and then flush back out to its normal, so that all the small bowel comes out of the colon, goes back into the abdominal cavity where it belongs, and now you've relieved the obstruction. You haven't necessarily said that the kid will never have another intussusception, but you have relieved the obstruction. The problem with this particular thing, this reduction of intussusception, is it is not infrequent that you can actually perforate the kid's colon by raising the hydrostatic pressure a little too much. Most radiologists, myself included, will not do these unless there's a surgeon essentially standing right next to me, ready to take the kid to the OR immediately. If there's no surgeon that's going to take the kid to the OR if there's a problem, I'm not doing it, because I've seen it happen a couple of times, and it can be very devastating if it's not taken care of right away. So these kids generally have, they have pain, they have vomiting, they have a palpable abdominal mass, usually in the right upper quadrant. They got rectal bleeding. Their stool has this currant jelly consistency to it, and can be reduced by barium enema, except that you can, if the kids are really, really sick, they got to go right to the OR, and you got to be very, very cautious about how you do this. Definitely one of the more frightening moments in a radiologist's career is when he's trying to reduce an intussusception on a little kid. Now, another way we diagnose it is with ultrasound. So ultrasound is also great because it's not ionizing radiation, and the bowel is generally pretty close to the skin surface, and it has a very typical appearance. So just picture in your mind's eye, a segment of bowel that is telescoped on itself. So there's a lumen, and then there's a wall, and then it's pulled some fat in, so there's fat, and then there's another lumen, and there's another wall, and then there's more fat. So it's like a donut, okay, of concentric layers of fluid, wall, and fat. And what you get then is this appearance of like a concentric wheel of abnormality where the patient's mass is. And, in the right clinical setting, you're going to look at this and you're going to go, okay, this kid has an intussusception. You can't really do anything about it with ultrasound, like you can try to reduce it with barium or gastrografin, but at least you can make the diagnosis. And if you can look at it with barium, and if you can look at it with ultrasound, you can look at it with CT. Right upper quadrant. Notice a few things here. This is the descending colon. It's collapsed. Okay. This is small bowel. It's dilated. Here's a concentric ring of abnormality. So you get this, and then you get this, which is probably fat that was around the wall of the colon that's now been pulled into the colon. Then you get another wheel of colonic wall, very typical for an intussusception in a kid. Another not particularly good thing to have is necrotizing enterocolitis. So let's just think about what it means, the words. Necrotizing means that something is dying, right? And enterocolitis, entero, bowel, colitis, inflammatory changes. So the bowel is inflamed, and it's inflamed to the extent that the bowel mucosa and wall is dying. And these are not good things to have. And what happens if your bowel has air and fluid in it and the mucosa starts to necrose? The air, the air in your bowel is going to start seeping into the wall of the bowel and seeping along the interstices of the bowel wall and even maybe get outside the bowel wall if it completely perforates. So the hallmark of necrotizing enterocolitis is this combination of infection, which leads to ischemia, or it could be ischemia leading to infection, depending on what's going on, and that you get hemorrhage in the bowel wall, necrosis, and then perforation. It's a very common condition in the premature neonate. So in addition to battling hyaline membrane disease, the kids are also struggling with necrotizing enterocolitis. So the bowel is essentially dying from inside. Flora, normal intestinal flora is making their way through the bowel wall. Also, all the nerves in the bowel don't know how to peristalse anymore. So the bowel starts to passively distend. The bowel wall gets edematous. There's this thing called thumbprinting, which is a radiographic finding, and frankly, I meant to look for a slide, and I think I forgot. But essentially, the bowel wall gets very edematous and looks like someone's been squeezing at it with your thumb. And then the air gets into the bowel wall, and you get pneumatosis intestinalis. Another, sounds like a big word, but if you think about it, pneumatosis means going to mean air, intestinalis in the intestine, air in the intestinal wall. And if there's enough of that air in the intestinal wall, it's going to get into the portal veins, and it's going to wind up in the liver. So you'll get air in the liver parenchyma, which is actually in the portal veins themselves. And then if there's a complete perforation, you may see pneumoperitoneum, which is air free in the peritoneal cavity. You may not, even though they may have perforation, you may not actually see the pneumoperitoneum. So look at a couple of pictures here. There's something very weird about this. And the weird thing is that, notice the air here. It's actually, it looks like it's in the wall of the bowel. Okay? I think the bowel is here. I think there's a loop here. There's a loop here. But the air looks like it's actually outside.
At what point does a child have normal?
Pretty quickly, like within a day or so, they're going to start to get normal flora. Of course, the uterus is a sterile place, so there's not going to be anything in there, right? But yeah, they're going to get colonized really fast. So with respect to this air, it appears like there's a beautiful picture of here's air inside the lumen, and then there's the wall, and then there's air in the wall and outside the wall like that. That is clearly not normal. This picture didn't show up too particularly well, but it's more of the same thing. There's air in the bowel wall. So necrotizing enterocolitis, definitely something that every radiologist is going to be looking for, and it can be devastating for the baby. A quick tour into some other things that are not bowel. This is hydronephrosis caused by a congenital obstruction of the urinary tract at the ureteropelvic junction. Again, we haven't done any GU, so I really haven't introduced you to too much of the anatomy or the terminology. But this particular image is one of contrast material in the renal collecting system. So these are the very dilated renal calyces, and then here's the big dilated renal pelvis. Here's the bladder, probably from the normal opposite side. But so this was probably an intravenous urogram or IVP, intravenous pyelogram, where they injected the iodine, and then over time took pictures of the abdomen as the iodine was concentrated by the kidneys and then excreted by the kidneys into the bladder. So when you take pictures over time, you can see the collecting system, the ureters, and the bladder. In this particular case, the contrast never got out of this collecting system because there's a congenital high-grade obstruction of the junction between the renal pelvis and the ureter. You can identify this in any number of different ways. Ultrasound, the intravenous pyelogram, which is what this is, a nuclear medicine scan, et cetera. So, you know, just an example of a fairly common entity called congenital UPJ obstruction. I had a medical school classmate who played football in college and was very, very fit. And then, like in the third year of medical school, he disappeared for a while, and he had to have his kidney removed because he had had a congenital UPJ obstruction for his entire life. Finally, the kidney was so big and distended, and the parenchyma was completely shot, that I think he got infected. But I mean, he lived, you know, into his mid-20s with this congenital UPJ obstruction. So it's not uncommon to see them as adults, and probably better to catch it as a kid. This is a study that we do for kids who have recurrent urinary tract infections. And when any kid has a recurrent urinary tract infection, the thing you're concerned about is that he or she, when they pee and their bladder contracts, that instead of all the urine coming out, some of it shoots back up a ureter and goes back up into the renal collecting system. It's called vesicoureteral reflux. So vesico means bladder, ureteral, ureter, and reflux. So going the wrong way. And this is graded depending on how dilated the ureter is, depending on how dilated the kidneys. But these kids get recurrent UTIs, and if it's bad enough, what they'll do is that kidney that is being refluxed into will never really empty very well. The parenchyma will slowly become atrophic, and the kidney will become non-functional. So you definitely want to find these. And unfortunately, the way you diagnose them, and the kids are at a very funky age because they could be anywhere between like 3 and 8 or 9 years old.
Is urine inside the bladder sterile?
It is, but any collection of fluid that is in a place where it doesn't belong long enough is going to get infected. Okay, this is largely true for anything in the body. The urine is sterile until it isn't, until it's been sitting there for a long time, and then something happens to get in there. And I would venture to say that we probably all have a few bugs running around in our urine, but because we're flushing it out all the time, they don't have a chance to dwell. But if you've got urine that's stagnant in any place, in the kidney, in the ureter, in the bladder, and it's sitting there and it's not flushing, that one or two or few little bugs that get in there, they're going to multiply and they're going to cause a problem. So the problem in these kids is that they're like 4, 5, 6, 7 years old. And what you got to do is you got to put a catheter in them. You got to opacify their bladder, and then you put them on a fluoro table. And while they're peeing, you have to take pictures. So you got to get like a 6-year-old to pee on command in front of everybody, and they just don't want to do it. They scream and cry. It can take. I've lost 20 pounds sitting there waiting for the kid to pee with the list. Trying to entice the kid. What can you say to a kid to pee? Oh, you want to go home? Mommy's going to buy McDonald's. Anything. Say anything. And then when they go, so if you fill their bladder up enough, they're going to want to go, right? But they'll fight you because they know that you're not supposed to pee unless you're at the toilet. You can't pee anywhere. They don't get it. And all I wanted to do was move on to the next case. But I was trying to be very good, right? So anyway, what happens here is, here's the bladder. The urethra now is open. The kid is actively peeing, okay? But he's also actively refluxing up this left ureter. So this is how you take these pictures really fast, and then you follow it up the ureter, and you take pictures and see if he gets it into the kidney and how dilated the kidney gets, and then you can grade it. But these are just very difficult to do. It takes a lot of patience. Maybe I didn't have. A couple of things, a couple of solid tumors for kids. Solid tumors in children are generally bad news. And just about the most common pediatric renal mass is the Wilms tumor or the nephroblastoma. So nephro means kidney. Blastoma is a term used to signify that the tumor is actually originating from immature, not completely differentiated cells. Okay, so a nephroblastoma is a tumor of the kidney that is basically originating from not completely differentiated kidney cells, and it's generally a very large renal mass, like here, and generally they get widely metastatic very quickly. 80% of them are in children less than 5 years old. Usually these kids come in with big bellies with palpable abdominal masses because they are generally large masses when they're discovered, and they displace adjacent structures. So you've got multiple liver masses here in a big liver. You've got a big mass here in this kidney, which is being squashed. So the Wilms tumor, I think we do better now at treating it than we used to, because these were uniformly like a death sentence for kids. But I think some of them do better now. There's another tumor called a neuroblastoma. So there's nephroblastoma, which is the Wilms tumor, and there's the neuroblastoma. The neuroblastoma is the most common solid childhood tumor that doesn't start in the brain, because pediatric brain tumors are actually the most common solid tumors of the pediatric age group. So this neuroblastoma is actually derived from sympathetic nervous tissue. Okay, so they are really neural crest origin tumors, and they also tend to be large. They tend to start in the adrenal glands, because the adrenal has two components. There's the adrenal cortex and the adrenal medulla, and they also tend to be large, and but they also can occur in other parts of the sympathetic chain, including the famous organ of Zuckerkandl, which is at the aortic bifurcation in the retroperitoneum. And in the posterior mediastinum, you've got sympathetic neural tissue in your mediastinum. So these things can occur anywhere along that sympathetic chain. They generally tend to occur in the adrenal glands, though. We're going to talk a little bit about non-accidental child abuse, and then we'll take a bit of a break, I think. This is pretty critical stuff to be able to recognize. Even every state has very stringent laws about reporting non-accidental injury in a child. We'll just leave the whole term of abuse of elderly people. And I'm talking right now. We're going to talk about the non-accidental injury for children. Even if I read from 30-something states, and I sit in my house and I read these cases. If I see what I think is non-accidental trauma in a kid, by law, I have to call that state agency right away. I can't rely on somebody else at the site doing it. I can't. If someone says, "Yeah, okay, I'll call," I can't do it. I would be liable if I did not call the state agency at any time of the day or night. So whenever we see non-accidental injuries in children, we have to go through this very stringent state-by-state process. And you probably are going to have to do it too. I'm sure it's going to be something that you're going to see. You're going to see it, and you've got to have a high index of suspicion for it. In an injury in any child that's non-ambulatory or totally dependent, when the history and the injury don't seem to be compatible, if there's been a delay in seeking medical attention, if there are multiple fractures in a kid, and the kid doesn't have osteogenesis imperfecta, those kids have, obviously are susceptible to fracture. But if that kid doesn't have osteogenesis imperfecta and has multiple fractures, you've got to be very worried. Any retinal hemorrhage, any history of a household fall that resulted in fractures. Fractures in kids really aren't all that common, especially from just kids being kids. So you got to be really, You gotta be really cautious about that, and you gotta just be very, very worried about it. Anytime you see a kid who's sustained blunt trauma and has fractures or other sequelae. So a couple of the more important findings I want to bring to your attention are the metaphyseal corner fracture and the posterior rib fractures. So we haven't really talked about the pediatric bone yet, as we're going to do in the next little bit. But really young child with the metaphysis of the bone, the epiphysis, the growth plate is going to be between. But here's this metaphysis. This is the part of the distal femur called the metaphysis. And there's this little buccal, little corner fracture right off the side of it. These don't happen normally. If you see this corner fracture, immediately you're going to start thinking about non-accidental injury. Posterior rib fractures in a kid. Posterior rib fractures in a child. It's almost impossible for a child to fracture multiple posterior ribs. It's not impossible if they get thrown against the wall. It's not impossible if they get beat with something. So anytime you see posterior rib fractures, remember the posterior ribs are more horizontal than the anterior ribs. These have been around for a while. There's 3 of them right in a row, and they're healing. But immediately you've got to be thinking about that. Yes. This is the knee, okay? So you can't see the patella yet because it's not ossified. Tibia, fibula, tibial epiphysis, femoral epiphysis, femoral metaphysis, corner fracture. Skull fractures in kids do not happen particularly often, especially if they cross a suture, like this one does. And about the most common place a kid will get an accidental skull fracture is going to be the parietal bone. Okay, so like you accidentally hit your head on the side of something. But if you've got a skull fracture in the occipital bone, like this one is, you've got to be very cautious. You've got to be very, very suspicious. If you have a child, this is an MR of the brain with subdural hemorrhages in multiple ages. I'll be right with you both, just a second. So subdural hemorrhage of different ages. So this one is older, and I know it just because of the sequences that are done. But you would be able to see something on CT where you'd be able to see a relatively acute hemorrhage superimposed on an older hemorrhage. So this is also going to be non-accidental injury. And shaken baby syndrome, this is what it does. This is it. These kids bleed. Subdurals, remember, are venous bleeds. The veins are very fragile. You shake a kid around until his head goes back and forth enough. Those venous structures are going to get torn. You're going to get this. Were there some questions?
Yes. The image on the left, what kind of image is that?
This is a 3D reconstruction of a CAT scan. Okay, so it's called a shaded surface display image of the skull. So it kind of looks like you're looking at a real skull.
It's really cool.
Yeah, it's cool. But here's your fracture. Right, it goes across the suture. Was there another?
Yeah, you said the provider word non-accidental.
Non-accidental injury.
The same as skull. How does occipital?
I mean, it's not easy to get an occipital skull fracture in a kid. The more common skull fractures are parietal. Okay, this is as if you were looking at the child from behind. Okay, I probably should have oriented you. Okay, so this is the occipital bone, parietal, but here's your fracture.
Is there a typical mechanism for those corner fractures that you're talking about in the paper?
There probably is, and I'm not sure I know. But I think it's mostly to do with kids getting, beaten. Okay, so blunt force trauma, someone just beating a kid about the legs, for example, catching that one. The important thing to know is that fracture does not occur when you fall off a swing or when you trip down a flight of stairs. That's not the fracture you're going to get. Okay. Let's take a break. Thanks.